minutes, I was asked to really focus on genetics of cardiovascular disease and the genetics of obesity. And my first disclosure is that I am not a geneticist. I'm a primary care doctor and an epidemiologist. But with our experience with having the Masala study over the last decade, we've been able to expand and include many other scientists, social scientists, and geneticists and other scientists to help us understand several aspects of cardiovascular disease. So if I could have my slides. Okay, as they come up, my first slide was a disclosure slide. I don't have any disclosures from any industry. So the way I'm going to structure the talk is really focus first on what we know about the genetics of cardiovascular disease among South Asians. And I think Dr. Bhopal as well as Dr. Rader did a nice introduction to that topic, and I'm going to show some of the new data that help understand a little bit more about the polygenic risk scores. We're having trouble with my slides, I see. So the most recent compelling data come from the UK Biobank study. And this was a nice paper that came out last year with the lead author Anirudh Patel and the senior author Amit Kara, both good colleagues of ours. And they looked at the UK Biobank data, which includes about 8,000 South Asians and about 450,000 European whites. And they looked at the incidence of cardiovascular disease in this group followed for about 8 years. And you can see the pink line shows a very distinct difference in the South Asian rates of cardiovascular disease for the entire length of follow-up, much higher than the European blue line. And if you look at that in terms of what is the difference in risk measured by a hazards ratio, South Asians had a twofold higher risk of developing cardiovascular disease compared to Europeans, and this is only in a demographic adjusted model for age and sex and which part of England they came from. And what they did really nicely was substantially adjust for very different risk factors, and you can see they adjusted for hypertension, diabetes, kidney disease, other inflammatory diseases, obesity, central obesity, cholesterol, Lp(a), C-reactive protein, family history. So they adjusted for everything they could with that data set. And there was still a residual 1.45 increase risk, or 45% higher risk of cardiovascular disease in the South Asians compared to Europeans that was unexplained by all of these risk factors. So they hypothesized that some of that unexplained risk may be coming from genetic or other biologic reasons that we have not added here. I will say family history is included, which is a kind of a surrogate measure for genetic risk if you think about, who in your family has had early heart disease. But nevertheless, so their group is very interested in pursuing the polygenic risk score. And so another paper led by Dr. Wang, by Amit Kara's group, looked at whether we could use the available polygenic risk scores among Europeans primarily. Can we apply that polygenic risk score to South Asians? And the bad news is we don't have a great polygenic risk score for South Asians, and because we are underrepresented in most genetic studies. So even though South Asians are almost a quarter of the world's population, only 1.3% of our genetics is in any of the studies that have ever been done. So you can see the South Asians in red, really a sliver of data, maybe really starting in 2016 to 2020. And this is terrible. And this is why, having more representation in research by South Asians is very, very important. So we can't build a polygenic risk score with very few people in who we have genetic data for. So do the genetic risk scores that have been made in that very blue and big population of Europeans, do they apply to South Asians? So that's the proof of principle that they did in this study. And so they looked at these predictors that were over, lots of variants, 6.6 variants in the genetic code. in 3,000 participants. They used participants in studies that came from India. And they looked at people with heart disease compared to controls with no heart disease and said, if we use that same polygenic risk score from Europeans, does it work well in South Asians? And what they found was, yes, it looks like as you have a higher polygenic risk score, so look at number 5 over there, the highest quintile of polygenic risk score that was made in Europeans does seem to actually predict higher cardiovascular risk in the Indians in this study. So there is some degree of understanding that maybe there will be something if we actually do have a polygenic risk score that's developed in South Asians, that maybe we will be able to have another risk factor. So that is something that Amit Khera's group is now pursuing with more data that's coming from India, Bangladesh, Pakistan, and we're happy to collaborate with our Masala data with this enterprise going forward. So the second part of my talk was really focusing on the genetics of obesity and body composition. What do we know about that? And we do know that the surrogate measure of obesity that we use in the clinic is body mass index. And we know it's very crude. It's a measure of your weight in kilograms divided by your height in meters squared. The WHO did suggest that clinicians use a lower BMI cut point for Asians because of data from other Asian countries that showed that Asians develop lots of comorbid problems at a lower BMI. So the BMI suggested to be used for overweight was 23 to 27.5 and obesity greater than 27.5. We are not using these BMI cut points regularly in the United States. So there is some work to be done to actually have clinical providers in the United States use correct BMI cut points for overweight and obesity in South Asians and all other Asian groups. So we looked at this in Masala, and Masala includes 1,160 South Asians from 2 geographic centers, Chicago with my co-PI, Dr. Nami Kandula here in the front, and San Francisco where I'm based. And what we did was we created Masala to be parallel to an ongoing study in the United States called the MESA study. So we could compare South Asians to 4 other US ethnic groups. And the South Asians are shown in red here. The first panel shows normal weight, and this is using the BMI of less than 23 for South Asians and Chinese that are in MESA. And you can see the prevalence of normal weight was about 25% of our South Asian population, and Masala had normal weight. And if you look at the overweight categories, almost all of the groups were around 45 to 50% were overweight. And obesity, about 30% of South Asians had obesity. And the other colors show you the 4 other groups in MESA and how the South Asians compare. So the question we had was, so we have 25% in the normal weight. Does that mean that that's good, that these people are very healthy and they don't have to worry about developing diabetes, developing heart disease? So we really wanted to focus on this group. And what we did was look at who is metabolically normal with a normal weight. So in the first panel, again, these are normal weight, so BMI less than 23 for the South Asians. And the red dot shows you those who are metabolically abnormal. And by that I mean they have some feature of the metabolic syndrome, high glucose, high blood pressure, high triglycerides, or low HDL. You can see South Asians had almost 45% of people in normal weight who were metabolically abnormal. And that was higher than the other 4 groups. The other 4 groups also had people in that metabolically abnormal but normal weight category. It was just more common in the South Asians. So what does this say? This says that if you have a normal BMI, and we're all shooting to get into that normal BMI range thinking that, oh, we're healthy, we're good. Not necessarily, because almost half of those people in normal BMI had metabolic abnormalities. And so what is a good BMI then? You're telling me that a BMI of less than 23 is not good or not normal? So we wanted to look at that same data to say, well, what's the BMI where a South Asian can actually say that that BMI should be okay and protective? And so we came up with these trajectories looking at different BMIs. For the whites, a BMI of 25 has about a 30% prevalence of having metabolic abnormalities. That's overweight for whites. And unfortunately, the South Asians, the BMI that's equivalent of the BMI of 25 in whites is a BMI of 19.6. So, there are big differences in where we put adipose tissue as well as this BMI marker in South Asians. So the bottom line is, as a clinical provider and as a patient, if you have a BMI that's 23 or lower, that does not necessarily mean that it's healthy, because we tend to look good, like you said, like Naveed said, but maybe we're not seeing the whole picture. And so there's been an understanding of these hidden fat depots for at least 20 years. The European gentleman, Dr. Yudkin, has a BMI of 22, normal. And his friend, Dr. Yajnik from Pune, India, has a BMI of 22, identical BMI, that's great. But when you use a whole body DEXA scan, shown in blue, the amount of body fat in the European man is 9% compared to 21% in the South Asian man. So there is excess body fat even with normal BMI. So in Masala, we spent some time to think about how can we measure this really well, the hidden parts where the fat may be hiding in areas that are not, they're not healthy. So we use CT scans to measure fat in the muscle, fat in the liver, fat around the abdominal intestinal organs, visceral fat, and fat around the heart. And these are some pictures of a cross-section of the CT scan through the lower part of the abdomen on the left, upper left, and we use software to quantify how much fat is under the skin, and that's shown in green. The light blue shows you fat around the intestines, and that's visceral fat. And then the light blue and the red muscles in the back shows you fat within the muscle tissue. Now, we can't use the same software in the liver. The liver, we use something called liver fat attenuation to see how much fat there is in the liver. And so what did we find? When we looked at this in our South Asian participants compared to the 4 groups in MESA, we found that South Asians store fat in all of the wrong places. So in the upper left is visceral fat. South Asians are shown in yellow. They have higher visceral fat levels compared to the other groups in MESA. They have more fat in the muscle, where fat should not be. They have more fat in the liver, where fat should not be. And they have less amount of total lean mass, which is muscle mass. So the muscle mass was lowest in the South Asians compared to the other groups. So what does this mean? Is this one of the reasons that there may be so much diabetes? So we did look at, well, what is the prevalence of diabetes in Masala? And this is again comparing to the 4 groups in MESA. And after adjusting for other risk factors that should be part of the reason that there's so much diabetes, you can see the overall prevalence of diabetes in South Asians was almost 27%, much higher than the 4 groups in MESA, much higher than the groups that the U.S. very much, knows are high risk, like African Americans and Latinos. The South Asian risk was the highest. And so how much of this can be explained by where the fat is? So now that we have the CT scan measures, we wanted to look at that. And what I want to show you is that here the South Asians are in black, and the other 4 groups are shown in the other gray and white bars. When we adjust for other risk factors, you can see the difference between the black bar and the gray bars gets a little bit attenuated. And when we add in those body composition measures of having fat in the liver, having fat around the abdominal organs, there's a little bit of a less of a difference between the African Americans and the South Asians, but there's still a difference. There's still unexplained difference for why there's so much diabetes in the South Asians. But body fat does explain a little bit. So in Masala, we've been fortunate to have ongoing NIH funding for the last 12, 15 years, and we've been able to see our participants twice. We're actually seeing them right now for a third time. And what we've been able to do is repeat measures of glucose tolerance in the. And what this shows you is people who had normal glucose tolerance or one of the three intermediate types of prediabetes, either impaired fasting glucose, impaired glucose tolerance, or both, and diabetes. And we've looked at how fast people progress to develop diabetes over time, because we've seen them 2 times now. And the overall incidence of diabetes was about 20 out of every 1,000 person years of follow-up, which is quite high. It's higher than most US groups that have been looked at. And when we looked at, well, what factors help us predict who is going to develop diabetes or who's going to progress more rapidly on this spectrum, what we found was having more visceral fat. So having fat around those organs was independently associated with progression from normal glucose to prediabetes, and having fat in the liver was also associated with progression to diabetes. It's an inverse measure here because the lower the fat attenuation, the greater the fat in the liver. So it's a little confusing, but both of these were highly independently associated, which is important because, one site and the other site are related, but not completely. So what does this mean? It's not an easy thing to, go to your doctor and say, I'm worried that I have, fat around my abdominal organs, and I'm worried that I have fat in my liver, and that this may be causing my diabetes. These are not necessarily tests that we do in the clinic, looking at, CT scans and other measures. So another group wanted to look at, well, are there genetic markers that actually tell you who's at risk of certain types of body composition? And I think this is very interesting. So this is using UK Biobank data, again, a really great data set, where they looked at people who had fat around their visceral abdominal area, and that's shown in the pink circle in that upper body scan. The second in the orange is people who have fat more around their abdomen area, but it's under the skin. So it's subcutaneous abdominal fat, which is less healthy, but not as bad as visceral fat. And the healthiest is the green, which is gluteofemoral fat. So that's fat around the buttocks and the legs. And what they found was, in this Venn diagram, that there's different genetic markers that really correspond nicely to those 3 different types of body composition, whether a person looks more like an apple or like a pear. And that's really interesting because we think there is a genetic basis for why South Asians are having more, fat in the liver and fat in the abdomen, but no one's ever been able to pin it down to 1 or 2 mutations. And it's probably going to be polygenic risk scores for abdominal fat that will be able to get us there to say, well, this person has more risk of having, more visceral fat, and this is something that may be more useful than imaging future in the clinic. So this is a really interesting paper that just came out last month that I wanted to add to my talk, because I think it's another way of showing how important these discoveries using genetic data are and will be in the future. So this is a study of 618,000 Europeans, and what they did was exome sequencing. So that's just using parts of the DNA that actually get translated into proteins, so not the entire genome. And they found 16 genes with really rare variants that they were able to map. And they found one shown in bold there, INHBE, which is a growth factor that's expressed in the liver. And that regulates whether or not there's going to be a lot of fat deposited in the liver. And this is really exciting because using this type of genetic study, we're able to pinpoint a protein that could be the target of a future drug. that could prevent fatty liver. And that's really, really exciting. And again, this was not South Asians at all, but this is the type of, the data that I think will drive new discoveries and new drug therapies in the future that will eventually be really helpful for South Asians. So I'm going to end with one slide because I want to make this, what's the take-home message in terms of clinical care. Yes, South Asians have about double the risk of cardiovascular disease, but currently our risk equations that we use don't capture this risk well. And Dr. Bhopal mentioned that there's about 20 to 30 risk calculators, and they're all fairly useless in South Asians. Genetics, I think, does play an important role, both for cardiovascular disease and body composition. However, we're not ready to use genetics in clinical setting, and because we don't have any data in South Asians. And I do think that preventive genomics, where actually, your doctor takes a blood sample, runs a polygenic risk score for diabetes, for heart disease, for body composition, I do think that there may be a future, probably 2 to 3 decades from now, that will be in the future. But that's really, really important for younger populations, because once you become older and have more and more risk factors, knowing your genetic risk is really not that helpful, because you need to be treating your risk factors already. This just tells you those who need to be treated more aggressively when they're younger. For now, I think it's really important that we all use our voices, we all use our sectors of influence to raise awareness of cardiovascular risk in South Asians. This has to be cross-sectoral. It's not going to be healthcare alone. This has to be the food industry, the entertainment industry, politics, everything has to really come together. As a clinician, as a primary care provider, I always ask about premature cardiovascular disease in all of my patients, but this is really very relevant in South Asian patients. And I measure risk factors, and this is something that all patients should be asking their providers to do is, think about waist circumference, think about glucose, blood pressure, lipids, Lp(a) one time, and maybe a coronary artery calcium score. And that we have really good data in Masala showing that is a helpful extra risk factor that tells you more information than all of these other risk factors in making decisions about who should start statins and when. Start making behavioral change. That last talk before mine really did say this, but I think the important thing is it has to be done with cultural humility. We have to take people where they are and see what they're willing to change and how we can do it in a way that would be sustainable. And medications, that we definitely talk to providers about getting on good medications. We have a whole slew of very well-proven medications that prevent cardiovascular disease, so there's a lot going on, and hopefully we'll add a little bit more to that list as time goes. So with that, I thank you for your attention, and I thank all of the participants and staff and everyone, and I know there's an internal medicine intern in the audience who's using Masala data to write 2 papers right now, so